everyone, it's Dr. Hill. I'm making a video today because I've been thinking about this topic a lot and kind of going through it in my head, trying to figure out how to make it a little bit short and sweet for you. Since February, March of last year, I have felt, and a lot of members of the medical community have felt, like we were in a war against a virus. We treated it the way we would a war. As soldiers, we were invigorated and excited to win the war, and we tried our hardest all last year and most of this year to try to win that war. But unfortunately, at this point in time, I have to say that we did not win the war in spite of our best efforts. And the reason why I believe we have not won that war and defeated the coronavirus is because, and entirely because, of politics and misinformation and lies on social media. So I thought perhaps if there are some of you who might benefit from hearing some of my thought processes rather than just straight out information, maybe you could realize how a physician thinks and why I've made some of the decisions that I have in regards to the COVID pandemic. So today's video is about the simple little topic of masks. Masks, I know, right? They were so politicized. It seems like everybody is far right or far left or anti-science, or somebody knows someone who knows someone on the internet who said that they worked at the CDC and masks are bad. I mean, and they just accept that at face value. Those of you who know me and have followed me on social media know that I've had a very pro-mask stance, except for perhaps a couple of you who noticed some points that I wavered on early in the pandemic. So I want to tell you how a doctor's mind evolved in regards to the topic of masks. I was raised by critical thinkers. My father's a professor, my mother's a doctor. I was raised to weigh pros and cons and to look at a logical argument even from the time I was a young child. In medical school, we are taught to study research studies, to look at things like the power of a study, the errors, the biases that might occur in the study, the sample sizes that affect a study. In fact, we had really annoying journal clubs where we would have to read journals and we would have to pick apart that article and find the flaws in it and find out if we believe that this was truly what we call a powerful study, a study that could be reproduced, and a study that was reliable and had minimal bias that could be identified. So we are taught to think this way, sometimes our whole lives, like I was, sometimes just in medical school. Some of us hated journal club and hated statistics, and unfortunately statistics is really important when interpreting data from a research study. So statistics, medical school statistics was a tiny little part, so you could easily pass medical school without doing that statistics. For me, I always thought the statistics on board exams were free points. For some people, they never bothered with them because it was such a small part of the test, and that's why sometimes you have physicians who are better at examining data and research than others, and some just really know how to do it and can't stand doing it, because I don't think any of us liked journal club or statistics. If you like statistics, you didn't go to medical school. So at the beginning of the pandemic, I would say the beginning of March 2020, I thought that we could identify people who had symptoms of COVID and that we could ask just the right questions and minimize the risk to us. We were very limited on masks at that time. In fact, if you saw, each one of my employees had a little cubby hole, and in that cubby hole was a brown paper bag for their N95 masks, and for their in a separate area in the cubby hole for their surgical masks. We had a UV sterilizer, a machine that I probably bought one of the last ones on Amazon that first or second week of March to clean our N95 masks and reuse them. And we had to do that because we didn't have enough supplies. In fact, our medical supply companies had been told if we put an order through to reject it. So we would put in an order and it would look like we were getting the supplies, and then we'd be like, where are they? And we'd go and look, and the order would have been canceled at the warehouse for the medical supply company. So we were very limited in our surgical masks. In addition to our N95 masks, we had 10 N95 masks that had to last us about 4 months at the beginning of the pandemic before the supply of N95 masks increased. So we were in a very difficult situation to protect ourselves. Initially, when someone suggested people wear masks, I actually started laughing at it. And most of you don't know that. But I laughed at it because I said, surgical masks protect other people from your germs. They don't protect you from other people's germs. So if my staff just wear surgical masks and all the patients aren't wearing masks, they're not protected at all, which is why I made my staff start wearing protective eyewear in the beginning as well, and harped on them about being conscious of their eyes, because almost all the early cases of COVID in the healthcare community subsequently were traced to exposure through their eyes, and that's probably a big part of why none of my staff ever got COVID. But I remember laughing and saying, it's not going to do any good for people to wear masks if everyone doesn't wear them, and you will never get everyone in America to wear masks. Furthermore, if we just asked our patients to wear masks, we would have to give them a mask when we asked them to wear it, and we don't have enough masks to go around. We tried to put masks in the waiting room in the beginning, thinking we could try to share some of our short supplies with patients, but what would happen is we would find them taking all the masks and putting them into their purses. And some of you who did that might be watching this video, and I don't blame you. I mean, everybody was worried back then, and you were too, but that led to us having to take the masks out of the waiting room, and that led to us not being able to offer masks to patients. So I didn't think that getting everyone to wear a mask was realistic or feasible. And even at that time, because in medical school, I learned and I understood that when we wore masks in the OR, we were protecting the patient from our germs. If a patient we were operating on had a disease that we were concerned was transmissible, we didn't just wear a surgical mask. We wore face shields. We wore sometimes those hazmat suits, astronaut looking suits, depending on how bad it was. You know, we never really expected a surgical mask to protect us from germs that the patient had. It was to protect them. And so with that understanding, I understood that unless we had the supplies and people were willing to all wear masks, there was no protection for us in just wearing a surgical mask. An N95 is different, but again, we had 10 of those to last 4 months, which is completely unreasonable. We had zero access to ordering new surgical masks after I found the first 10 in the very first few days before schools closed down or anything else. As it hit Georgia, that was one of the first things I got, and those are the only ones we had until the supply opened up late in the summer. So I did not ask people on social media to wear masks, and I wasn't convinced that you would ever get everyone to cooperate, and I knew that we didn't have the supplies for it, and we couldn't give the patients the supplies. So we put on surgical masks, protective eyewear, and attempted to screen for COVID symptoms in the beginning to minimize the risk to us and to our patients. The only way we had to protect the other patients, even though I felt like we were adequately protected when our eyes were covered and we had gloves and our mouth was covered, but we still had other patients to think about. And the only way at that time I could think to protect them was to try to screen for COVID symptoms. After a while, though, it became clear that COVID can present as almost anything, and screening for it became harder and more frustrating, not just as we realized there are more symptoms of COVID that we didn't know about, but also as people lied to us about their symptoms because they wanted to be seen. It was not unusual for someone to come into my office and say that they had no COVID exposure, and after 10 minutes in a visit with them, they tell me that they had been diagnosed with COVID and tested positive 3 days earlier, but they didn't believe it because they felt fine. I mean, that actually occurred quite frequently. So again, we were wearing masks and eyewear, but I became more and more concerned about protecting all our other patients, particularly the most medically fragile, and the parents and the grandparents who came in who were on chemotherapy or who had immunosuppressed conditions. And so it became harder and harder to screen that way. As that difficulty became apparent to me, people were making cloth masks and they were distributing them quickly. And in the beginning, I also thought that was silly. I laughed at it. I had an employee who wore a cloth mask at work, and I just started laughing. And I said, you won't wear that in the office. It doesn't help enough. That's silly. You can wear it over a surgical mask if you want to for decoration and take it home and wash it so that you can reuse that surgical mask underneath longer, but you won't replace a surgical mask with a cloth mask. I didn't think there was any way they could really help. I just couldn't imagine any circumstance where a cloth mask would be adequate. But then research came out, like real research, medical research that showed viral particle penetration of various types of masks, cloth masks, surgical masks, N95 masks, and the viral size, and started to show that in a laboratory, a cloth mask did have some significant decrease in the transmission from the person wearing it to others of COVID particles. And so as I saw that information start to come out and be reproduced in multiple research studies, I realized I had been wrong about cloth masks. And while they weren't quite as good as surgical masks, they were definitely better than nothing. I also read research that talked about how COVID at this point, which I understood was airborne, unlike the media just telling people now, I understood that when I saw the hospitals spending money on retrofitting rooms with reverse isolation, which costs a lot of money and we only use for airborne diseases. When I saw them start to do that, I thought, somebody's clued them in that this is airborne and we don't want to talk about it. And so it was as I realized that COVID was airborne, I moved more and more patients to the parking lot to be outside. But I also read research that showed that it takes 10 minutes face-to-face contact time of normal conversation between two people without masks for COVID to be transmitted from one to another, and 20 minutes face-to-face time when you have a cloth or surgical mask. And that kind of real-world information that again was reproduced in multiple different research studies. We studied stuff like the difference in just speaking and the spread of COVID versus singing and shouting and laughing and the spread of COVID. There was so much data coming out fast and furiously in medical journals that I became convinced that cloth masks could work. And I stopped making fun of them for two reasons: because I believed it could cut down on the spread of COVID, and that had been shown and reproduced to me in research studies in the laboratory, and also because the availability of cloth masks became better. So I realized it was within our reach to be able to ask all our patients to wear masks. Again, this was for the protection primarily of our patients and their families, because by this time we were starting to get better supply of surgical masks for us, and I wasn't stressing out about reusing a surgical mask quite as much. And I realized that none of my staff had gotten COVID as they were covering their eyes and their mouth and wearing scrubs and wearing gloves. And so it became more about protecting the other thousands of people who we see with COVID by asking everyone else to wear masks. I also became more convinced through the research that if everyone was wearing masks, that we would all be protected a little bit better against COVID. So you can see my thoughts on masks evolved over time. There were a couple things that I differed with, and probably still differ with the CDC, because I feel it's logical. One is that I never believed that people should have to wear masks outside when they aren't around other people. If we believe this disease, this virus is airborne, which we do, being outside seemed to be the best cure for not catching COVID, as was shown over and over with indoor versus outdoor restaurants and other settings. I felt like it was kind of silly to tell people to wear masks, and I felt like that got politicized, and it helped other people think that masks that people who were on the side of masks were kind of like just ridiculous. And yes, I do feel like a political agenda on one side or the other was being pushed, because that never made sense to me. Now, wearing masks when you're outside around a lot of people, absolutely, if there's a chance you could have COVID or something and you're going to be in very close contact with people outside, but just running or walking down a jogging path, like that never made sense to me. The other thing was that young children, until the UK variant, were not spreading COVID. Over and over, we demonstrated that children were not vectors for the spread of COVID, until, of course, with the UK variant and now the Delta variant and some of the newer variants, we know that kids do spread it. But back last year, young children were not known to spread COVID, and there wasn't really any data to say that they did. And so some of you might have noticed a couple times when I posted not wanting my kindergartner to wear a mask to school, because I genuinely believed that under the age of about the age of 5 and under were not spreading COVID. And that's what the data said. That's changed with the new variants, but that's what it said back then. And so the WHO, said that people over 5 and over should wear masks, but the CDC said 2 and over. And so I disagreed on that, not now, unfortunately, because we've allowed the new variants to develop, but I disagreed back then because that's not what the data showed. So as this thought process on masks evolved, there was one other thing that made a huge difference and ramped up my social media efforts to try to get people to wear masks. And that was the fact that I did not believe in asymptomatic shed with COVID. I had arguments with other physicians, with friends. Data would come out talking about how maybe as much as 50% of the COVID transmission came from asymptomatic shed. And I kept saying, that's not true. That can't be true. That's not how viruses work. People get sick when they're contagious. You know it. More and more data started coming out talking about asymptomatic shed, and I was very reluctant to believe that because I just never seen a virus really work that way before. And in July, I was one of the first primary care offices to get my hands on rapid COVID testing. And I did that, some of you know, because I work pro athletic events, and Georgia reopened to pro events. And so I got rapid testing to use on athletes for our athletic commission so that big events could go on safely. So the first event, I tested all the athletes and all the ancillary staff for the event. I tested between, I think, 120 and 150 people. And this was in the second week of July of 2020. And when I tested these people, I found that 7 to 10% were positive for COVID, and none of them were symptomatic. They were all young, healthy, without a single symptom. And subsequently, they didn't go on to get sick as I followed up on this. And when I realized that, I was horrified, because I realized not only was this virus airborne, but people who didn't even know they were sick could transmit it to other people. I saw it with my own eyes. This one particular point, I'd read data, I'd read research study, and it still didn't convince me because it went against what I felt was common sense. But when I saw it with my own eyes, I realized I had been wrong. And if asymptomatic people with no symptoms, can spread an airborne disease to other people, all of a sudden I realized the true importance of masks. And it's at that time that I started a campaign on social media to try to get more people in our community to wear masks. Not a single decision that I made in regards to masks was ever made because of a political reason. It was never made based on just a recommendation from WHO or the CDC. Not a single decision that I made in regards to masks had anything to do with anything except for scientific data and research that I saw published multiple times, reproduced in a reliable manner.